Good morning, everyone. Sabah al-khair jami'an. It's a real pleasure to be in this very special conference. I'll try to talk very quickly through the endoscopic bariatric complications or emergencies. It's a whole field, and now there are bariatric endoscopists. So many things and complications, but I'll try to focus on two main things, which are the leaks and the outflow obstruction. Leaks, they are truly a catastrophe. When you have a post-bariatric surgery leak, it's really like a storm, and it's nothing to be taken lightly. This is just a case to show an example of what we mean. This is a patient who presented with fever and was sent to us for assessment of a leak 2 weeks after a bypass. Here we're at the end of the esophagus, and then after we pass the cardia, we try to figure out the lumen. We first think that this is the lumen in front of us, and then we find out that this is actually all a dehiscence of the jejunum. This is the jejunum, and this is the actual lumen. So it's actually almost a complete disruption of the anastomosis. And our role now as endoscopists is not to run out and leave this and send it to surgeon, but is to do what we can to try to improve the situation a little bit, because what we need to understand is that there are very little solutions for surgically for a situation like this. So what we do actually is we go in this cavity. Now we're in the peritoneal cavity. We clean it as much as we can with saline. We use even Dormia baskets and tripods and so on to remove all the debris and make suction. And then we try to perhaps approximate this leak. Of course, we do these also on the fluoroscopy. It's essential. You see here the contrast going everywhere. In this case, we decided to do some approximation of the edges using the Ovesco clip. We use here the twin grasper to try to approximate the edges. Of course, it's not easy. Some edges are fibrotic, some are friable due to the infection. And once you approximate, you try to apply a clip. In this case, we applied 2 actually Ovesco clips, but you have to know very well that it is impossible that these will hold things in place. It's not that simple when you have leaks. These will not be alone. These only help to approximate. So we also put one of those large mega stents. You see here the clips in place, and put the stent on top. And we left this patient for about 8 weeks. And then we had a look, and we removed the stent. And we see here that things look a bit better. Now you see here the jejunum, you see here the lumen, but there is still some track that hasn't sealed completely. And now you have to change the strategy a little bit. This is now a chronic leak. It's not an acute leak. Here, this track, it has epithelialized. So when you have epithelialization, it will be very hard for this to seal on its own. So we had to change a little bit the approach, and we started to do some de-epithelialization of this track by using APC, of course on low settings, because the aim is just to make a new raw surface area to help the aiding of the closure of this track. And we did it all the way up to the end. And then we also applied for another time a mega stent, and we left the patient for 6 weeks. And then we came in to see this beautiful sight, and the patient eventually healed. Of course, this is a very nice edited video. Life is not that nice and simple. This is very complex. These are very difficult patients. As we saw in our study that we published back in 2018, yes, we reach a success of about 82% in healing these leaks endoscopically, but these are very, very traumatic and very morbid. Over 90% of the patients have severe pain and vomiting. We had even bleeding and perforation, so you really have to be careful when you approach these patients. Putting a stent like this is not like putting just a biliary stent. They are really traumatic. We actually cooperated with one of the companies in Korea to modify it to make a stent that is much more flexible and much less sharp to reduce this rate of complications. There are other ways, like endoscopic internal drainage, which has gained popularity, and I really like it now. It's a different approach. So when you find a leak like this, here at the GE junction, you see it endoscopically, you actually pass a guide wire, and with the same principle of treating a pancreatic pseudocyst, the aim is just to drain the leak collection to the inside of the lumen. So we put here double pigtail stents. And you leave the patient for 4 to 6 weeks, and then you remove them, the cavity collapses, and it's healed. This is one of the international studies that showed, yes, the success is about 80%, but you always, in more than half of the cases, you use multiple ways and multiple sessions to treat the patients. As I said, these are very difficult patients. It's not easy. If someone sends you a patient with a leak, you have to know the following. This is a patient who's already obese. He has so many comorbidities. He's already in the ICU. He's very risky. His chest is not good. This is a patient that will stay with you and keep you up for the following maybe 2 to 3 months. You will give him your phone number. You will not just leave him and go, because he might complicate any time. There are complications that come, of course, with the patient and his parents. It's not easy, because no matter what you tell the parents, we are going to try something, it might not work out. Many of the patients, they don't like this thing not working out. He comes to you after 2 or 3 months. Look, I still have the leak. It didn't work. We're not happy with that, so we have to be ready. There are legal issues about this that you always have to be aware of. You might cause complications. The surgeon might disappear. You might be stuck with the patient. They say it's your responsibility. The patient died and it wasn't, and so on. And finally, the problem of the cost. Many of these patients come to you. I have a leak, but I spent all my money on the bariatric surgery, and now you have to treat me. Or the surgeon comes to tell you, okay, I will pay for the treatment of this patient, but please don't pay too much because I don't have much money. And then you're in this very, I know this is, it's a terrible situation. It shouldn't happen anywhere. I know for our friends from Europe, for them this might seem very strange, but this is the situation in Egypt, and you have to keep all these things in mind. Quickly, for the time, yes, we do treat strictures. Yes, you can treat them by stents. But what is new is that when you have a resistant stricture, we can use the third space endoscopy techniques, which I start to really like and use very frequently to approach these very hard strictures. This is a nice video from my friend Diogo Moura in Brazil, and he shows the principle where you do a tunnel to reach the site of the stricture, and then you cut the fibrosis and the muscle to relieve this stricture, and then you close the site. This is an example of a patient who had a very tight stricture at the incisura after a sleeve gastrectomy. So what we did here is we are at about 5 centimeters above the incisura along the staple line, and then we do an incision, we do a tunnel, we enter in this tunnel, and with the aim to expose the underlying muscle and fibrosis at the level of the stricture. And then, so yeah, here we're doing the submucosal tunneling in this blue submucosa. And then eventually when you finish your tunnel here, the submucosal tunnel, you start doing a myotomy. You see here the fibrosis by the staple line, and you cut at it or beside it. And we actually cut here in a full thickness. So we start by selectively cutting, and then we cut the full thickness of the muscle and the fibrotic tissue. So here you see, this is the peritoneal cavity. We have cut the muscle, but we are safe. We can do that because we are covered by the mucosal layer above. This is the edge of the liver coming out here. But again, it's okay as long as you will be able to close the mucosal edge. And this is what we did after we finished. So this is we've cut the fibrosis and the muscle here along the staple line, and then we stapled by clips our mucosal entry site, and then we looked at this patient about 5 weeks later. And you can see here, it's a very now easy and wide passage to the antrum. For the sake of time, I will pass this, but yes, sometimes we do have pylorospasm, and we also treat it endoscopically, also by the same technique, by doing submucosal tunneling in patients who do have a pylorospasm after having a upper GI surgery. Sometimes, in this case, it was a sleeve gastrectomy. So in conclusion, in cases of leaks, you have to be really patient. It's not a one-time procedure. It's not like doing an ERCP to remove a stone. In leaks, there are many techniques that are not competing, but they have to use them complementary. You have to know which one to use in which situation. You must have an open mind. You can't be stuck to one thing. This is something very frequent. A surgeon sends you a patient. He tells you, please put a stent. You can't do that. You can't go on. You will tell him, look, I will see. I'll do the endoscopy. What is suitable for this patient, I will do it. Maybe he needs a double pigtail. And finally, yes, we do include third space endoscopy. It does offer many options. And at the end, you really have to tread carefully with bariatric complications. As I said, they are very difficult cases to approach. And thank you very much.